My job is to talk about vaginal progesterone, which I think is far easier to talk about than Jamie's job. You did a terrific job. Thank you very much for doing this. It's great when you can work with one of your friends, and Jamie and I have been friends for a long time. This is the same slide that he showed you earlier about the history of progesterone use. You can see that FDA approved Crenone in 1997. And when Crenone first came out, we actually had a little bit of experience with it in my practice. I run a group called Texas Fertility in Austin. And we tried Crenone, and we didn't like Crenone. So it just didn't work very well for our patients. We did have a lot of luteal bleeding, and we went back to intramuscular progesterone, and that's where we stayed until a sequence of events happened a few years ago that I'll walk you through in just a few minutes. The case for the use of vaginal progesterone, well, we know that vaginal administration delivers progesterone directly to the uterus, and that's really where the progesterone needs to go. It doesn't need to go to the breast. It doesn't need to go to the systemic system. It doesn't need to go to the brain, because we all know the side effects the systemic progesterone exposure can cause. And there's a lot of data that are emerging now, hopefully they'll see the light of publication soon, that show that in fact it is selectively taken up when you administer progesterone vaginally into the uterine vessels and into the uterus itself, where it exerts its effect. It was proven equivalent to IM progesterone in a large prospective randomized trial. I'll show you those data in just a minute. These results are supported by another large prospective trial. And we know that vaginal progesterone has been proven to be equivalent to IM in replacement cycles in both prospective and retrospective trials. And then finally, we do know from satisfaction data and surveys that are out there that patients really don't like intramuscular progesterone. Newsflash, I'm sure that you would never have figured that out on your own. You needed to have some survey to tell you that. Patients don't like IM, and they really do want a replacement. They want something different. So how is this delivered? Well, potential benefits of vaginal delivery. We know that targeted delivery can help ensure high uterine drug levels with low systemic exposure. Jamie showed you Ciccinelli's study, really fascinating study, 14 patients, prospective randomized, who were scheduled for hysterectomy. And what they did was they received intramuscular injections of progesterone the day before and the morning of their hysterectomy, compared to vaginal patients who received Crenone the day before and the morning of surgery, and then they did a hysterectomy. They took serum levels, and they also measured uterine tissue levels. And what they found were profound differences. And I'll walk you through those data in just a minute. But the bottom line is there's a first uterine pass effect, and so even though intramuscular progesterone gives you levels 6 to 7-fold higher than what you can see with vaginal progesterone, the vaginal progesterones have uterine levels that are 2.5 times higher than the intramuscular progesterone, and that's where we want the progesterone to go anyway. This is the data from what you can see from Ciccinelli's study. So you see endometrial levels 1.05 compared to 0.43, so 2.5 times higher with the vaginal progesterone, whereas the serum levels were 6-fold higher with the IM progesterone than with the vaginal progesterone. But serum, does it really matter? Sam Chantilly subsequently showed that in fact serum levels probably don't matter. They're not predictive of who is and who is not going to conceive, and you can see there were no differences. Ongoing pregnancy rates were the same in patients, 33.5 in the Crenone patients, 36.1 in the IM progesterone patients. They had about 80 patients in that study. So the use of vaginal progesterone in IVF, this is Elena Janusz-Polsky's study. Interesting study. It came from the Harvard group, and the significant thing about that is this is the exact same group that shot Crenone down the first time that it came out. Tony Probst was the first author of the paper. Tony's a great guy, did really good research with the old applicator for Crenone. They used the applicator that was available in the 90s, which was subsequently changed. But what they found was that, in fact, Crenone was not efficacious, and it was not superior to IM progesterone. Elena did the same study, prospective randomized trial in women under the age of 40 undergoing IVF. They stratified their patients by age. So patients were stratified under 35 or 35 to 39 before randomization. After a positive pregnancy test, all patients were transitioned over to Crenone because that's in fact what they're now using in their group. 407 patients, again, prospective randomized. They were equally distributed between the two groups. And what you can see is Crenone was started 2 days after the egg retrieval, whereas the intramuscular progesterone was started the day after the egg retrieval. And the reason for that is this suspicion that in fact maybe Crenone is absorbed better into the uterus, and perhaps maybe you don't need to start it as soon. So that's how they constructed their trial. What did they find? No statistically significant difference in ongoing pregnancy rates. Crenone was numerically favored, 45.2% compared to 42.2% in the intramuscular group. What they also found to address the luteal phase bleeding issue that Jamie really touched on a lot, and that is that among non-pregnant patients, so non-pregnant patients, you do see more bleeding in the vaginal progesterone group than you do in the intramuscular group. However, there was no statistically significant difference in the incidence of bleeding among pregnant patients. So the vaginal progesterones don't cause or precipitate bleeding, apparently, in pregnant patients. But maybe if you are not pregnant, you may start bleeding a little bit earlier. This is a study that we published in Fertility and Sterility in 2012. This study was not funded by any pharmaceutical company. My partners and I paid for this study ourselves. We had no financial support whatsoever. And what we did was we did a prospective trial. It started out prospective randomized, and through a funny sequence of events, we ended up reporting it as prospective non-randomized. Tertiary care private practice setting, we looked at 511 consecutive IVF patients going through IVF at Texas Fertility from April 2008 to April 2009. 474 patients completed the study. The only patients who did not complete the study were patients who did not have an embryo transfer. So we had a lot of patients who came through retrieval for oocyte vitrification before cancer treatment, et cetera. We had patients who had no fertilization. We had patients who we did pre-implantation genetic screening on. We did not include them in the results either, although they were in fact equally distributed between the two groups and didn't change the results, but we didn't want to report them because we did a lot of embryo manipulation there. The dosing, we gave Crenone once a day in the morning, 172 patients, and we gave intramuscular progesterone 25 milligrams a day to patients 39 years of age and younger, and 50 milligrams a day to patients 40 and over. That was 302 patients in that group. And we started both progesterones on the same day, and that was 2 days after egg retrieval. We found a statistically significant difference in terms of delivery rates. So these are live birth rates in all patients of all ages. 51.7 live birth rate in the Crenone group, 45.4% in the IM progesterone group. That was statistically significantly different. So this is the largest study now, prospective design, that shows a statistically significant difference in favor of the vaginal progesterone. There's another study Kevin Duty published in Fertility. He was the first author in Fertility and Sterility. This was a big study that was funded by Ferring Pharmaceuticals. And what they did was they looked at the different vaginal progesterones, Crenone once a day, endometrione twice a day, and endometrione 3 times a day. Found no statistically significant differences in ongoing pregnancy rates between those three different formulations. So what about replacement cycles? There are some data looking at replacement cycles. This was the original pivotal trial. Bill Gibbons was the first author, published in 1998, 72 women. They were randomized in advance. It was decided to use a 7-3 randomization. 7 patients out of every 10 received Crenone BID, because again, this is replacement for donor cycles. And IM progesterone was given 100 milligrams once a day. And what they found was that there was a statistically significant difference in clinical pregnancy rates, 48% compared to 28%, and then ongoing pregnancy rate also 31% compared to 22%, again in favor of the vaginal progesterone. And you may say, well, wait a minute, that's really nice. There was a statistically significant difference, but I would never tolerate those donor rates in my program because these are really low rates. But I'll caution you again, this is 1998. Data is when it was published. The study was performed in 1995, and in 1995 we weren't as good as we all are now. Berger study, this is a retrospective evaluation published in March of 2012, looking at 225 donor egg recipients from donors that were under the age of 32. And what they did was they used vaginal progesterone gel and intramuscular progesterone starting on the afternoon of the egg retrieval, and they continued until a negative pregnancy test or 10 weeks of estimated gestational age. And again, they found numerically in favor of the vaginal progesterone, but no statistically significant differences. So the vaginal progesterones in purple, you can see positive pregnancy rates, clinical pregnancy rates, delivery rates, and then pregnancy loss rates, all in favor numerically of the vaginal progesterone with no statistical significant difference observed. Patient satisfaction, we know that patients are more satisfied with vaginal progestins. That's kind of a no-brainer. Everybody intuitively understands that. This is a study, 206 patients in the progesterone vaginal group and 201 in the IM group. On a scale of 1 to 5, the vaginal progesterone group, the Crenone group, had a score of 4.4, the intramuscular 2.8. That was statistically significantly different. So just to summarize quickly, vaginal progesterone has been proven to be equivalent to IM in a large randomized prospective trial. That was the Lani Janusz-Polsky study. These results are supported by another large prospective study. Our study, which is the largest study now, actually shows statistical superiority both for patients under the age of 35, or 35 and under, and for all patients. Our patients had statistically significantly higher delivery rates, live birth rates. That's all we looked at. We didn't look at just clinical pregnancy rates or ongoing. We looked at birth rates. Vaginal progesterone improvement equivalent to IM in replacement cycles in prospective and retrospective trials, and patients were found to be statistically significantly more satisfied with the vaginal progesterone.